Or we can go to next talk on the treatment by Dr. Jayesh Vazirani, who's a cornea specialist, ocular surface specialist, trained at PGI Chandigarh and a fellowship and faculty at LVP. And Jayesh, please.
Right. So good afternoon, everyone. My topic is medical management of peripheral ulcerative keratitis, and these are my financial disclosures. So the definition we've gone through, we know that PUK can be associated with inflammation of the adjacent tissue, sometimes can also have uveitis. The pathogenesis has been covered in great detail, and why peripheral cornea, that has also been discussed, so I'm not going through it again. Right, so let me just start with some cases. So this is a 43-year-old man who has symptoms for about a week in the right eye, and the left eye he has had low vision for many years. So we can see that there is a peripheral ulceration in the right eye, in the nasal periphery of the cornea, and the other eye also seems to have had some sort of perforation which has healed, and now the patient has an adherent glaucoma. So this is case 1. Case 2 is a slightly older woman who has had symptoms for about 2 weeks, and you can see a very classical looking furrow or a peripheral ulcer with some infiltration, thinning, and there is congestion in the eye, and this is how the other case 2 looks. This is case 3. So pseudophakic both eyes and has large perforation with iris prolapse in the right eye. The other eye is also showing thinning in the corneal periphery in the inferior half. Right, so please keep these 3 cases in mind. So how would we proceed with this? So it has been outlined in the earlier talks that there is a protocol for this. It's very logical what to do. So the first thing we do is ask some questions which may be pertinent for the eye, as well as if the patient has any systemic involvement, which we usually look for when we look at PUK. And then you do some targeted investigations. Not all of these are always necessary, as Isha had pointed out. One can do a basic screening, and then based on the clinical manifestation, systemic as well as the ocular, and then go to the other investigations. All of this is there in the handout, which the QR code, you can just scan and get it. So these are the typical signs that you look for. You look for the joints, you look at the skin, you look for nodules, you look at the teeth, the salivary function, and then you also ask some questions about if the patient has any visceral involvement. Why? Because we know that a lot of etiologies of peripheral ulcerative keratitis do have systemic correlates, and the commonest that we see in our clinics is rheumatoid arthritis. The second commonest is ANCA vasculitis, but then you can have a lot of others which other speakers have shown. And this has already been discussed, that apart from the systemic issues, you can have local causes, so that can be infectious or non-infectious. And these are the specific laboratory tests for each condition, but we don't need to go into this. So this was the first case. So you can see that if you look at the patient, he has a rash, there's a skin rash, it looks very erythematous, there is a facial skin rash. He's had a very interesting and complicated history. He has had arthritis, septic arthritis was the diagnosis. He was admitted with a fever of unknown origin, and he's had multiple organ involvement over the past 2 to 3 years before he came to me. The Sherman test shows reduced tear production, and also he has this kind of corneal picture. The second case, the lady that I talked about had very obvious joint deformities in both the hands as well as the toes. She had dry mouth and very highly raised RA factor. So when you see this, what you're looking at in both of these cases is PUK associated with a systemic disease. It was rheumatoid arthritis in this case, case 2. In the first case, the rheumatologist felt it was an overlap between RA and SLE. So there's an overlap where cases can have features of lupus as well as rheumatoid arthritis, and that gentleman had an overlap of RA and SLE. So the management is medical as well as surgical. So medical therapy can be local and systemic. Systemic therapy, as has been emphasized throughout this course, is critical and very important. So the systemic therapy can be done in 2 ways. As Dr. Sangwan was suggesting, if you are really interested and you have the inclination, you may want to train yourself, and if you're trained well enough, it's not very difficult to figure out which severity, which cases, how severe it is and what kind of drug to use. However, if you feel that you need the support of someone, these days it's not very difficult to find rheumatologists in almost every major or even slightly smaller cities. So you just need to take them on board and convince them that despite the patient may or may not having systemic manifestations of disease, the eye disease is severe enough to warrant systemic therapy. So the medical therapy is the key part here, and the other things are adjunctive. So if you do just surgery, it is going to fail. So if you want to do surgery, it should be done under the cover of appropriate systemic therapy. And why is it important? Because as Dr. Sangwan was alluding earlier, these patients, and there is a lot of evidence, so this paper is older than I am, but it basically says that if a patient has PUK or scleritis, and the patient has a systemic disease and that patient is not treated systemically and not treated aggressively enough, it's very likely that the patient will not survive over the next 5 years. So the patient will die, forget about the eye. So even for that reason, the patient needs to be on systemic immunomodulatory therapy. What are the drugs that we use? There are quite a few, but you can categorize them into mainly these agents. The most important and the ones of immediate use are corticosteroids. That will buy you time for you to use another drug. And then you have alkylating agents, antimetabolites, T-cell inhibitors, biologic agents, and these are the newer ones, the JAK-STAT inhibitors. So the general principle is you match the severity of the condition with the drug that you want to use. So if you have a case where the globe integrity is threatened, so you have a PUK which is perforated or is about to perforate, you also have necrotizing scleritis, you don't really have time for the slower acting drugs. So you need to give them a reasonably high dose of systemic corticosteroids. Usually we use intravenous methylprednisolone, 500 milligrams to 1 gram a day, and you repeat it over the next 2 days, so about 3 days. Simultaneously, the drug of choice for these cases has traditionally been cyclophosphamide. So it was earlier very long ago given orally, now is usually given in intravenous pulses. So you give intravenous cyclophosphamide. An alternative to this is a CD20 inhibitor called rituximab, but cyclophosphamide is much cheaper. And then once you have achieved a sufficient degree of control over the inflammation, you may want to switch over to oral steroids in tapering doses, and the tapering needs to be reasonably slow. And then once you have, let's say, given 6 pulses of cyclophosphamide, one usually tries to step down to something like mycophenolate or azathioprine or methotrexate for maintenance of the remission. There is a certain degree of monitoring involved of the liver parameters, the renal parameters, as well as the blood pressure, blood counts, because some of them can have bone marrow toxicity, some can have toxicity on the liver and kidney, but this is not very difficult to do. So drug-specific serum levels are needed, as Dr. Syed was alluding to, for T-cell inhibitors, cyclosporin and tacrolimus, but this is only when you use them in very high doses, the doses that are typically used to prevent organ transplant rejection. For the doses that we need in the eye, there is some literature to suggest that you need not monitor the serum levels. So I'll come to, for example, this case, as I was saying, here the globe integrity is threatened. So here this is the this is the regime that I used. So IVMP 500 milligrams for 3 days, followed by oral prednisolone 1 milligram per kg, and this is tapered over 2 to 3 months. The patient is given pulses of intravenous cyclophosphamide, and once the eye is quiet, one can shift to a milder drug. And then with appropriate therapy, it quietens down. So you don't really need surgery, even for cases where you feel that it's a very bad case. If you don't have an imminent perforation, then one might want to give just oral prednisolone to begin with, and then taper it slowly and match the severity of disease with an appropriate immunosuppressive drug. So for these 2 cases, what we did was we did not use intravenous steroids, we used oral prednisolone, and both the cases simultaneously methotrexate was started. Methotrexate acts well for rheumatoid arthritis in general and also for PUK associated with RA, but it takes time. So it's not as quick as cyclophosphamide. This was the 3rd case. Here everything was negative. So all the labs were negative, and Dr. Sangwan told you about Watson's criteria for Murren's ulcer. So this is bilateral Murren's ulcer, and there also there is a stepwise treatment protocol. I'll go back.
This is what I was referring. These exactly are the 5 criteria, and that was proved. He enunciated them clinically, but then it was proved by a study from Arvind and a group in US with a prospective study, and now if you understand these, then you don't really need to do a systemic investigation. Thank you, Jayesh.
Right. So Moran's ulcer, this is a free article in IGO, and now there are more recent articles, but more or less the protocol remains the same, that you have a step ladder approach to treatment. So starting from topical steroids, going on to conjunctival resection, systemic immunosuppression, additional tectonic surgeries, and then rehabilitation. So this case, again, we gave IVMP for 3 consecutive days and then oral prednisolone, cyclophosphamide pulses. And after we had given IVMP and the first dose of cyclophosphamide, did we operate? So the patch graft was done after and not before, and that is important, right? So the differential diagnosis Dr. Murthy has talked about. So this again is HSV associated ulceration, which looks similar to PUK. One may have associated lid margin disease, and you can have recurrent or chronic blepharokeratoconjunctivitis, which leads to peripheral scarring, sometimes peripheral inflammation and thinning that can also mimic a PUK. So here the treatment is local. If you have HSV, you need to treat appropriately with antivirals and sometimes steroids, depending on the tissue involved. If you have chronic blepharokeratoconjunctivitis, you look at the cause of the blepharitis, whether it is anterior or posterior. A lot of these cases are associated with Demodex infestation, so you want to treat that. And then give topical steroids, and usually it quietens down. So these cases do not need systemic therapy. So the take-home messages from this talk would be that PUK is an inflammatory corneal disorder driven usually by systemic autoimmunity. It is often accompanied by episcleritis, scleritis, and sometimes even uveitis. Moran's ulcer is when you don't have any systemic associations, but systemic evaluation is essential. So for both the evaluation and the therapy, you need to determine whether you are equipped to do it or not. So my suggestion is that if you see these cases very rarely, it is best to send these patients as early as possible to the nearest ocular surface specialist or cornea specialist who knows what to do. And they in turn may want to treat this themselves, or they may want to liaise with a physician or a rheumatologist. And once things are quietened down, the patient can be shifted back to the comprehensive ophthalmologist for monitoring and follow-up. Right. So I'll just plug a few things here before ending my talk. So we've been doing a very interesting meeting called Ask Me Anything, AMA, at Ahmedabad since 2018, which focuses on ocular surface and corneal issues. And last year we combined it with another meeting called the Ocular Surface Workshop. So it was OSW AMA. This year again we'll be doing it in September at Ahmedabad. So it is comprehensive ophthalmologists are welcome to attend. Some of the things are a little advanced, but I'm sure you'll find something useful. But definitely if you're a cornea specialist or an ocular surface specialist, you'll find it a very good meeting. So it's very informal, non-hierarchical, and everything is very clinically relevant. And this year we've decided that it is going to be a no-text meeting. So we are going to stipulate to all the speakers that you are not allowed to use any text on any of your slides. So it's going to be a very interesting meeting. We also have an observership program at Ahmedabad. So if you feel you have any young people who are interested in cornea and ocular surface, this is not a long-term fellowship, so there's no surgical exposure, but a lot of clinical exposure, and they get to know all the protocols. So that is the QR code for the observership program. And with that, I'll say thank you very much.
Thank you, Dr. Jayesh, for a very comprehensive and interesting talk. Yeah, the mic's working, yeah.
Any questions from the yes? Second last slide. Could you please observership program?
Can you put up his slides again?
Doctor, can you please use the mic just behind you? Yeah.
The Ask Me Anything program, is it a hybrid program or
No, it is not. By design, it is not hybrid.
Okay.
We don't even record it as a video.
Okay.
So if you want to be there and ask me anything, you have to be there.
Okay. So every year it's in Ahmedabad only? Or?
Yes. The OSW has not always, it has been traditionally at LV Prasad Eye Institute, Hyderabad, and it will probably return to Hyderabad later, but this year it will be in Ahmedabad.
So any questions?
You can just meet me. I think we don't need to put up those, and I'll give you the links to either the QR codes, yes.
So before we have the last speaker, questions
Well,
regarding...
he also wants to see some slide. Which slide?
Last slide.
I'll give it to you. I'll give it.
you the details.
Is asked. Right. Please use
role
the
of
mic now.
tacrolimus. So tacrolimus traditionally, well, at least in my practice, I have used at least over the past 7 to 8 years extensively for ocular allergy. Personally, I have not used much for PUK or scleritis, but the rheumatologist that I liaise with saw me using tacrolimus for allergy, and she's saying that she adds it to cases of recalcitrant scleritis or even PUK, where they're not subsiding with methotrexate or azathioprine, and apparently it is very good.
So
So
is the
T-cell
question-
inhibitors also work.
Is a question about topical tacrolimus?
Oh,
Topical
okay, I misunderstood. I'm sorry.
So he
We
was talking about
really don't
systemic.
think in terms of eye drops for these cases, so
See,
it's my mistake.
See,
Right,
this is a disconnect.
right.
When we are talking about PUK, we are talking mostly systemic.
I just assumed you were asking about tacrolimus tablets, but topical tacrolimus, no role, no role.
So what all of us are agreed on, at least on this side,
Right.
is that PUK is a systemic disease. So the driver is systemic. So we have to suppress it systemically, of course, barring the infections and the local causes. So the pure PUK, whether it is Murins or it is with an autoimmune disease like rheumatoid arthritis and so on, or you cannot find the autoimmune disease and it's not looking like Murins, but you have PUK. So all these three categories need systemic immunosuppression. So when you talked about tacrolimus, he thought immediately that you were saying systemic, and I knew where you're getting at, because we do
So
use...
madam looks a bit scared with the talk of all these drugs. So, but if these are just drugs, like you use Dimox or you use antibiotics.
Dr. Sangwan, but
Yeah.
here I would tend to slightly disagree in the sense that when you said you should learn by yourselves, yeah, that is good, you can, but I think that so that the ophthalmologist or the specialist can focus more on their practice, it would be very good to have a very nice partnership. Not everybody is Dr. Sangwan here, so it would be, there's no other Dr. Sangwan.
I will tell you the story.
But yeah, so just to complete that, it would be good to have a very good sort of a partner. And it's, sometimes we have our colleagues, we have people from our own batch or whoever we have, find that kind of partner or the medical colleges and so on. And over a period of time, when you develop that connection, then you can have the systemic part of it, they really help you with that. And they do know more than what we know. Like tacrolimus, for example, your rheumatologist pointed that out, and you wouldn't have had the benefit of that. And we are still sort of backdated with whatever drugs we used, and now they have moved forward and they use various other drugs which can be helpful to our patients as well. So I have a patient of rheumatoid arthritis with scleritis and PUK, and now what is really helping her is tofacitinib. On my own, I would have never started it.
Yeah.